Good morning or good afternoon. My name is Dr. Vishwanath Danthaluri, in case you were wondering how to say that, but you can call me Dr. D if you would like. If you're seeing me today, you must be here for a bariatric surgery consultation. I look forward to meeting you, and I thought it would be a good time to go ahead and start learning about the four primary operations from which you have to choose. So let's get started. Before we cover those surgeries, let's watch a very nice, succinct video that will tell you a little bit more about why you might have struggled to lose weight up until this point.
You might know someone like Amanda. She's a 42-year-old mother with a 6-year-old son. Her baby is just starting first grade, and Amanda looks forward to seeing him grow and enjoy a happy life. But Amanda is she will not live long enough to see him finish high school. She's been struggling with her weight, and in recent years, it has become a serious threat to her health. She is dependent on large doses of insulin for her diabetes. Her joints are so painful that she can barely walk beyond her garden. Amanda has worked very hard to lose weight in the past. She tried many types of diets and worked with weight management specialists to control her weight. Even though she lost some weight with each new diet and exercise routine, the weight always crept back on, and then some. She wanted to lose the weight on her own, but she felt like her body just kept failing her. What Amanda didn't know is losing weight and maintaining weight loss is a lot more complicated than simply eating less and exercising more. Historically, people have believed that body weight is determined by the energy balance equation. If you consume more calories than you burn, you gain weight. If you burn more than you consume, you lose weight. We view obesity as a lifestyle choice, and the cure for it is simple: eat less and exercise more. This assumption may sound logical, but it can be wrong. One theory, called the set point theory, suggests that no matter what you want to weigh, your brain has a certain weight range and body fat level that it works to maintain within the set point range. This means that you don't control your body fat consciously. Rather, your brain manages it like it does your breathing and heart rate. Your brain receives information through hormone signals from your body fat, muscles, pancreas, liver, GI tract, and sensory organs at all times, and controls your appetite, digestion, energy balance, and metabolism. Once your set point has been elevated, your body works to defend it vigorously. What happens when Amanda starts a diet? She might be able to lose some weight temporarily, but hormone signals from her body change in response to weight loss and tell her brain to increase calorie intake and slow down calorie burn to restore the body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning calories slower than before. Amanda's body doesn't recognize that her set point is too high and her weight is unhealthy. It only knows to defend her current set point. Her system like a house with a broken thermostat. If the thermostat gets set too high, you might be able to cool the house down temporarily by opening a window, but the sensor would detect the temperature change and heat it up again until it reaches the temperature set by the thermostat. This might explain why treating obesity with diet and exercise so often fails to produce the desired results. It's sort of like telling Amanda to open the window to let some cool air in, when the real problem is that she needs a mechanic to fix her thermostat. Okay, so if the set point system prevents us from losing weight, why doesn't it also protect us from gaining weight and developing obesity in the first place? It actually takes a perfect storm to cause an obesity epidemic. Changes to the chemical and nutrient content of our food, the so-called Western diet, a decrease in physical activity, increased levels of stress, inadequate and disrupted sleep, and more widespread use of medications that affect metabolism and promote weight gain, all appear to play a role in elevated set points and rising rates of obesity. And Amanda responded to those environmental changes by sending hormonal signals that elevate her set point for body fat. What can you do with the elevated set point? Back to our thermostat analogy. Amanda's room temperature was set too high, and she needs to lower her thermostat temperature. Or, in other words, find a way to lower her set point. She needs to find a way to make her body regulate itself to a new lower weight. One option for Amanda to consider is bariatric surgery. In study after study, it's been shown to currently be the most effective long-term treatment of obesity. So how does bariatric surgery work to help people lose weight and maintain that new lower weight? Most people, even many doctors, think that bariatric surgery works only for restricting food intake or preventing calories from being absorbed. This is true, but there is more to it. Research suggests that certain types of bariatric surgery also affect the signals between the brain and the body and cause decreased appetite, increased feelings of fullness, increased metabolism, and even preferences for healthier food. These surgeries appear to produce signal changes that reset the body weight set point to a new, healthier level and stop the brain from encouraging weight regain in response to dieting. Bariatric surgery may also affect hormones that help to regulate your overall health, which may explain why some types of bariatric surgery can resolve or improve type 2 diabetes. So, here are 3 things you can take away from all of this. 1. Body weight and body fat are highly controlled by a complex system. 2. Obesity is a disease where the complex system that controls body fat may malfunction, resulting in a set point that is too high. 3. Bariatric surgery may work by changing the signals that control the body fat set point, enabling patients to successfully lose weight and keep it off for long term. Bariatric surgery is shown to be the most effective long term treatment for obesity. To learn more about surgical
With that
obesity
information in
treatment and the
mind,
journey for a
let's start
healthier
learning
life,
about these
visit
surgeries.
www.thehealthpartner.com/WLS.
Now that you have an understanding about why you've gained weight over the years and had trouble getting rid of it, let's look at the surgical options and get a sense of how they work. There are 4 operations we are going to cover today. Please keep in mind if it feels overwhelming or like I've moved too quickly, I will be with you by the end of this PowerPoint and we'll make sure all your questions are answered. Let's start with the sleeve gastrectomy. The sleeve gastrectomy is a surgery where we cut and remove 2/3 to 3/4 of the stomach forever. Leaves you with a rigid banana-shaped tube for your new stomach. The idea here is that it is restrictive, meaning we're restricting what you eat, allowing you to feel fuller faster, stay fuller longer, and less hungry between meals. What we're not doing is changing your normal anatomy for how you digest and absorb calories for the most part. This is the critical mixing point indicated by the star. From here to the end, normally, and as you sit here today watching this video, you probably have 16 to 20 feet of adult intestine to absorb calories. This surgery, because we're leaving that alone, has the reputation of being the safest and simplest surgery to do, and I also believe it has the added benefit, although I wholeheartedly hope we pick the right surgery for you that'll last you a lifetime. With the sleeve, you're not burning any bridges. This surgery can be converted to any of the other 3 surgeries at any point in life, and relatively speaking, although revisional surgery can be dangerous, revision of a sleeve to any of the other surgeries is safe to perform. That being said, I want to talk about this tool a little bit more. This surgery has one tool built into it, which has the name restriction, which I'm not the biggest fan of. You may have heard or may read that the sleeve has a high rate of failure. Well, what is failure? For most people, it means that they did not lose as much weight as they were hoping or regained weight sometime after having the surgery. I think a common reason this happens is twofold. Number one, your friends or loved ones or people whose experiences you're reading about may have seen a surgeon who only specializes in the sleeve and has no other tools in their toolbox. In that case, a patient could be misled to think that the sleeve is going to get them to their target weight. Here at Beltline, we will decide on what surgery suits you based on the estimated weight loss and hopefully set better expectations right out the gate. Secondly, though, and this is where our excellent support and aftercare programs can help you, one thing I don't want you to do is to fall into the common trap of relying on restriction. I think this is a big reason why people regain weight. The classic story I always share is that I had a patient during training that had come back 5 years after a sleeve having regained all of their weight. We did an EGD scope on that patient, and the sleeve wasn't dilated that much, but it had grown a little bit. However, when talking to that patient and having talked to similar patients since then, I hear one common story over and over. Patients will say, Dr. D, I lost weight that first year, and it was really easy because the sleeve would tell me when to stop eating. Now I can sit with my family and eat a full regular meal again. What I would like to educate you on to set you up for success is the fact that although this rigid banana-shaped tube cannot stretch back to normal, tension mechanics, or physics, if you will, allow for a slight change in diameter to dramatically change how much a tube like this can actually stretch. You don't need to have a normal sized stomach to eat a normal meal, and if you're eating the wrong things, things that melt in your mouth and trickle through here, will never stretch the stomach out and give you that feeling of fullness. I try to advise everyone by the end of that first year, when you lose weight, primarily from that metabolic rate thermostat that was reset, to train yourself to learn how to eat without chasing physical fullness or psychologically chasing satiety. You should feel comfortable getting up and stepping away from a meal, even if you don't feel like your stomach is completely full. It's easier said than done, which I understand. You could start right away by training yourself to eat to where you still have room in your stomach for a hearty cup of fluid like water or enough space for another few bites of food. In that situation, this can remain a great tool for you long term, and occasionally, if you accidentally overeat, it will still tell you. I think that's the best way to get long lasting results out of this. And mind you, there's still a 60% long term success rate with a sleeve, which means at least 60% of people didn't cave to their food addiction or relapse on bad eating habits and have used this tool to maintain their weight and maintain their restriction. So it is possible. Before we leave this page, I want to highlight two complications that actually apply to all the surgeries and one unique side effect of the sleeve. Anywhere we cut an organ, it could fail to heal. In the situation of cutting intestine, if you don't heal, you can leak bacteria into your belly and get a bad infection. That's called a surgical leak. Now, the sleeve has the lowest risk of that complication at generally 0.5 to 1%, and I usually say 0.9%. The more things we cut and rearrange, the higher that risk. The other risk that's common or is well known with all of these weight loss surgeries has to do with the intestine, and that's malnutrition. That's getting low on critical vitamins, amino acids, electrolytes, other things that your body needs to function normally. It's the easiest problem to avoid if you are compliant with bariatric vitamins, which we'll educate you about. As you sign up for surgery today, go ahead and mentally sign up for daily bariatric vitamins, and this should not be a major problem for you. Last but not least, the sleeve, as I called it a rigid banana-shaped tube, it also means it's a high-pressure tube. For some people with other underlying conditions, some of which I hope to catch and address, which I'll cover at the end of this PowerPoint, but others which we may not detect, can lead to this surgery being associated with a 20, sometimes 30% risk of a new onset of heartburn or reflux problems. If you're having bad reflux, I'm going to screen you for some things that we can work on, and I may direct you to think about the gastric bypass, which is our best anti-reflux surgery. Again, the main reason we lose weight with any of these surgeries is the metabolic component, but study after study has shown that the metabolic benefit only lasts about 9 to 15 months after the surgery, and so you will reset back to normal, and you will still have a remarkable God-given ability to absorb calories and put them on your body. As extreme as surgery may be, we are not undoing thousands and thousands of years of evolution. Next is the gastric bypass. This surgery involves providing you with restriction in the form of a teacup size pouch, but also another tool called malabsorption. In this surgery, although it looks complex, nothing is removed from the abdomen. The key feature is that we're going to change where that mixing happens. In the first part of the surgery, we make a pouch. In the second part of the surgery, I split the intestine and reroute it up here to make connection 1. The other end is connected here to make connection 2. Now food travels down this side of the tubing, relatively speaking, undigested, because all the stuff that has to break the food down has to travel a little further to meet up with it downstream. From the new mixing point, if you will, which is shifted downward, to the end, I estimate, is about 10 to 12 feet of intestine or common channel to absorb those calories. So we're decreasing the surface area your body has to interact with the food. This can allow for more weight loss up front, whereas the sleeve allows for, I usually say 50 to 70% excess body weight. The bypass should offer somewhere between 60 to 80% excess body weight. In some respects, I do think this can protect you for some time against weight regain, but here at Beltline, we do several bypass revisions every year because people find us after regaining weight having had their bypass years ago. So I want to underscore how important it is to change that lifestyle and diet and use us regularly so you can get the best results and not find yourself in a chair seeking revisional surgery. Unique complications with this surgery, there's a 2 to 5% lifetime risk of getting an ulcer right here. The main reason is smoking. The second main reason is NSAID drugs. These are Advil, Aleve, ibuprofen, Motrin, Excedrin, and hopefully you don't use this, but Goody's powders. These drugs are essentially poison to the pouch and can cause an ulcer in as few as a couple of doses. Ulcers are bad because they can cause nausea, vomiting, pain, or worse, bleeding, and rupture and infection. Once you've had a bypass, I'm going to advise you to list NSAID drugs as allergies to remind you lifelong not to take them again. To be clear, Tylenol is not an NSAID and can be used safely. So one thing you'll want to tell me when I come to see you is whether or not you're already relying on NSAID drugs for common issues like knee, back pain, or migraines. The other issue with a bypass, and specifically due to cutting the bowel and using a two-connection technique, I believe, is something called a small bowel obstruction. This can cause nausea, vomiting, bloating, inability to pass gas or have bowel movements, and sometimes can be an emergency. Sometimes an internal hernia can occur here, causing your obstruction and can compromise the intestine in a way that in 0.1 to 1% of cases may require small bowel resection or removal of a segment of bowel. This is an excellent anti-reflux surgery, and the malabsorptive procedures have a better chance of curing diabetes. So again, as I come in and consider your past medical history, your goals, your risks with you, and your desired weight loss, that's how we will land on the surgery that's best for you. Keep in mind also, with malabsorptive surgeries, anywhere we've manipulated intestine, but also the sleeve does have a slight risk of this. There is a risk of something called dumping syndrome. Syndrome sounds like a disease, and I hate that word. And instead, you'll hear me call it a slap on the wrist for reaching in the cookie jar. Dumping syndrome can cause pain, nausea, bloating, and most memorably, urgency to the bathroom, as well as several other symptoms. But it's easily avoided by eating the right way. Do not eat high carb or high fat meals after these surgeries, and you should avoid those symptoms. The next surgery is the duodenal switch. This is basically a combination of the first two surgeries. It's a sleeve up top and a long bypass down below. In fact, from the mixing point to the end, which is shifted down here, is now only 3 to 4 feet. So this is the surgery where the vast majority of the intestine is bypassed, and for this reason, it can lead to the most weight loss. I will tell people to estimate somewhere between 80 to sometimes 95% excess body weight loss with this surgery. However, we do like to reserve it for extreme BMIs and multiple medical problems. Why do we do that? I do worry sometimes that if we do this surgery for um, the wrong reasons, we could set you up for higher risks of some things that are a little more well known to happen with the duodenal switch. Number one, this surgery does have a higher malnutrition risk than the sleeve and even the bypass. After all, it is the most aggressive surgery. Again, for most patients' life, taking vitamins is how you avoid that problem. But I have seen as our intestine atrophies, as does the rest of our body as we age, where in the 60s or 70s years of age, we may need to do something to help your nutritional status. Although that is rare, it does highlight the fact that the duodenal switch has the highest malnutrition risk that I'm aware of. The other risk with this short intestine, for some people, it can cause a chronic diarrhea, especially for the first year. It may not be uncommon for a small fraction of people to have 1 to 3 bowel movements a day. I think for many of those people that complain of that, they're still not following the diet properly. However, once in a while, we do have a compliant patient that is having frequent stools. I think if we wait beyond the first year, this intestine should learn how to deal with that. So it's not a problem for many patients beyond the first year. But I usually quote a 2 to possibly 3% risk of chronic diarrhea with the short intestine. It's still a two connection technique, so connection 2 is at risk for that bowel obstruction. Last but not least is the SADI. And although we're talking about it last, it should be positioned in terms of how it works and weight loss between the bypass and the duodenal switch. The SADI, which is not new to where you need to worry about it, it is relative to the other surgeries new, but it has been around since about 2007. So we have solid 15-year data. This surgery involves utilizing the sleeve up top. Again, if we go away from using the bypass tiny pouch and connecting bowel directly to it, we reduce that ulcer risk. I should remind you, even with a sleeve, there's not a 0% ulcer risk, but it is much more rare. That's your restrictive component. The bottom part's going to be done differently from the last two surgeries. Instead of splitting and making two connections, we're going to drag this bowel up like one long garden hose, if you will, and connect it at a point that's roughly 7 to 9 feet from the end. That number, as you can figure out if you're paying attention, is almost perfectly between the 10 to 12 feet of the bypass and the 3 to 4 feet of the duodenal switch. I like to believe that this surgery came about when it did and was designed to reap all the benefits of the weight loss surgeries that we talked about before, but limit the risks. And here's how I think that works. Because it's a sleeve, we have the lower ulcer risk. Because we didn't use two connection technique and we used one connection technique, there is a lower bowel obstruction risk so far. I usually say 1% or less. Also, with 8 to 9 feet of intestine, we have started to believe or have determined that this is probably the optimal length to maximize weight loss, as in some series we see the SADI patients lose nearly as much weight as they do with the duodenal switch. However, we have a lower malnutrition risk and a lower diarrhea risk. I usually say less than 1% risk of diarrhea and a lower malnutrition risk because we have more absorbing capacity, or at least we should. The caveat with the SADI is, although scientifically speaking, I do not consider it new or any longer a research-based surgery, Conveniently enough, some insurances do, and mostly it's because they don't want to pay for it. However, as of the time of this PowerPoint, many insurances are now getting on board and meeting the high demand for this surgery. Last but not least, I want to talk about two additional items that may go along with your unhealthy weight and may need to be addressed at the time of your weight loss surgery. One item is called the hiatal hernia, paired with gastroesophageal reflux disease. As it turns out, having an unhealthy weight gives you a 21%, or actually, I think it's higher, north of 30% risk of having a hiatal hernia. What is a hiatal hernia? Well, the hiatus, first of all, is a hole in the diaphragm that we were born with so that the food carrying tube, the esophagus, can pass through it. When it passes through the hole that's here, should be snug enough that it just lightly touches the edge of the esophagus. However, it should be snug and airtight. When you have a hiatal hernia, that diameter there starts to increase. The diaphragm muscles don't push solidly against the esophagus, and particularly they don't push in the right spot. And this can exacerbate or worsen GERD symptoms. If you struggle with sleep time reflux or regurgitation especially, I think that's a higher predictor of a hiatal hernia. What I'm talking about is when you lay down after a meal, you feel food and or fluid come up into your lower chest or up into your throat or mouth, and that could mean there's a disruption here. That would be in addition to the classic symptoms of heartburn, bloating, discomfort, which constitute GERD as well. I have a separate PowerPoint on GERD should you want to learn more or talk or refer a friend or family member to discuss their long-term GERD symptoms because there are surgical options for this. Very important, and as it relates to seeing me today for weight loss surgery, especially if you are really choosing the sleeve, I want to screen you for the severity of symptoms and potentially screen you with an X-ray to see, at a minimum, an X-ray to see if you have a hiatal hernia. In some situations with mild symptoms and a known hiatal hernia, we may proceed confidently with your surgery of choice if it happens to be a sleeve, as long as we can do a good hiatal hernia repair. So this is why I want to talk about GERD and potentially screen for this as we make a final surgery decision. And realize overweight or obese patients have GERD at a rate of, again, 27 to probably over 30% rate. And as I said, if present, we want to fix a hiatal hernia for sure. Venous insufficiency, this is not something we need to address right away, and we may want to do it after your surgery is done in the recovery months. However, as with GERD, having an unhealthy weight can be a reason that you suffer from venous insufficiency. Situations that create high pressure in the belly, i.e., carrying a lot of weight in your central abdomen, and for females, long pregnancies and maybe even the pushing events where you dramatically increase the pressure could cause these valves in our leg veins to fail. The way blood travels around your circulation after being pumped out by the heart and running through the elastic artery vessels is that they eventually trickle through single lumens or single cell tunnels and then enter the venous side of the system. On the vein side, veins don't have elastic walls that can spring open and shut. So as you walk, you should pump blood up. And then, very elegantly, we're designed with valves to keep that blood moving in one direction. If the valves get diseased, blood pools in your legs, much like dropping the dam on a river, and then the tributary creeks and other tributary streams all start to overflow. That's how you get engorgement of the veins in your legs. This could lead to achy, sore legs at the end of the day, swelling legs, and sometimes we have found that there's an association between restless legs and venous insufficiency. So if you want to talk about this, we can offer ultrasound screening dates for this to figure out if you have it. We can immediately try to treat this with compression stockings and some recommendations. And should any of that fail, we can talk about a simple 30-minute to 1 hour long in-office procedure that we can do to take care of this for you. If you don't have these issues, but you know someone who does, feel free to also encourage them to talk to us about it. That's all I have for now. As I said, I'll be with you shortly. I hope you enjoyed the educational video. I hope you have some good questions that I'll be more than happy to and ready to answer. Let's see if we can get to know each other, look at your history, look at your goals, the predicted weight loss with these surgeries, address your concerns, and then hopefully select the surgery that will help you get to your goal. I look forward to seeing you. I will be in shortly. Thank you.